you everyone for coming. I'm delighted to get this opportunity to talk to you about metabolic surgery. I'm going to give you some of the clinical perspectives that have led to ongoing research and have given us some molecular insights into the pathophysiology, not just of obesity, but also of its complications. So I'm sure I don't need to draw your attention to the prevalence of obesity. It's obvious that it's a problem in the Western world, but particularly in Ireland, where now 1 in 4 Irish adults are obese, and we're on target to be the most obese nation in Europe by 2030, which is an alarming statistic we shouldn't be proud of. It's a very expensive disease. It has a personal cost to the patient affected by the disease, but also to society and to our healthcare system. So it causes about 2,000 deaths per year. And the direct costs alone, just in healthcare costs, amount to well over 1.1 billion. That doesn't even take into account the cost of its complications, such as diabetes and heart disease. We know that 80% of patients who have the disease of obesity also have complications of the disease. And that's what's really important about it, because those complications have a mortality rate. The complications include diabetes, sleep apnea, heart disease, to name but a few, and the rest are illustrated on the diagram. And we also know that these can improve or even go into remission if somebody can lose about 10% of their body weight, which is achievable, because obesity is a treatable disease. And even though it is the most chronic disease in Ireland at the minute, it doesn't have a funded treatment programme, but the treatments are available and they can be effective. A lot of people think losing weight is about eating less and moving more, and whilst that's true for preventing obesity, it's not enough to treat it when it already exists. But nonetheless, 1 in 5 people who have the disease of obesity and undertake significant changes to diet and lifestyle can manage to achieve a 10% weight loss and keep that off into the long term. But that's not successful enough for the majority. We have better medications now that can help people to lose weight, including a GLP-1 analogue called liraglutide or semaglutide, which can help people to, about 1 in 3 people who take the drug, achieve about 10% weight loss at best. But our work in understanding obesity and its complications is helping us develop better medications all the time, but we're far from there yet. But that leads me to bariatric surgery, which is by far the most successful treatment for the disease of obesity, in that over 9 in 10 people who undergo this surgery, who have the disease of obesity, can achieve and sustain more than 10% weight loss. In fact, the typical weight loss result from these surgeries would be to lose about 25, even 30% of body weight. And I'll show you the additional benefits of surgery in a few moments. So over the next 25-30 minutes or so, I'd like to tell you what is modern day bariatric or metabolic surgery. And you'll notice I do use the terms interchangeably because bariatric surgery focuses largely on weight. Baros is the Greek term for weight, but metabolic surgery describes better what these procedures actually do. They achieve weight loss, but far more than that. So metabolic surgery is probably the preferred term at the minute. I'm going to show you how well it works, and again, that's just looking at our clinical perspectives, our clinical outcomes, and then we'll discuss a little bit about how it works. There are certainly mechanisms that are dependent on weight loss. We've also insights now to show that there are certainly weight independent benefits of these surgeries, and I'll give you an insight into the types of research in this field that we're doing here at UCD. So there is a definition of metabolic surgery that's quite broad. It's the operative manipulation of a normal organ or organ system, such as the gut, to achieve a biological result for a potential health gain. So essentially, these are operations that exert their outcomes via neurohormonal mechanisms. And in metabolic surgery for obesity and type 2 diabetes, for example, these are operations on the gut that lead to neurohormonal changes in the hypothalamus in the brain, which is a centre that controls appetite and satiety. So the concept of metabolic surgery is not new. It dates far back to even 1896, when probably the first metabolic surgery operation performed was a bilateral oophorectomy, and that was observed to induce regression of breast cancer, clearly through endocrine manipulation. And from there, the next metabolic surgery operation identified was probably gastric and vagal nerve procedures, including Billroth 2, which was popular for peptic ulcer disease at the time. Then in the 1950s, the first intestinal bypass was described for the treatment of severe dyslipidemia. That led in 1972 to the first randomised control trial that used metabolic GI surgery for the surgical control of hyperlipidemias. That was called a POSH trial at the time. And a notable side effect, although that was intended to treat dyslipidemia, a notable side effect was significant weight loss. But there were undesirable side effects secondary to profound malabsorption and malnutrition. So it was largely abandoned in the late 70s. But then around that time, the pioneers of bariatric surgery wanted to focus on the weight loss benefits of this intestinal bypass. And in fact, they started noticing similar weight loss results when subtotal gastrectomies were performed for gastric cancers. And from there, the first true metabolic or bariatric surgery operations evolved, which was a Roux-en-Y gastric bypass. This caused far less malabsorption than the jejunal-ileal bypass I mentioned, but did achieve similar weight loss. So it showed that you could get the balance right between weight loss and preserving nutrition as best possible. And then it was only in 1994 that the first laparoscopic gastric bypass was performed for obesity. And from here, the exponential growth of bariatric and metabolic surgery evolved. So as bariatric surgery grew in the 90s, it was performed primarily still with the intent of achieving weight loss. But a simple clinical observation by this man, Walter Porres, who's probably one of the great pioneers of bariatric surgery, soon transformed the way surgeons thought about these operations. So Walter Porres started to repetitively see normal blood glucose levels in his patients with obesity and type 2 diabetes within hours of performing a gastric bypass. So at first he actually thought the glucometers weren't calibrated properly, and then blamed the nurses for not taking the blood sugars properly, repeated them over and over. But when he saw this over 500 times, he started to believe that this was a real phenomenon. And for the very first time, it appeared that type 2 diabetes could be put into remission without drug treatment. So he was noticing normal blood sugars the day after a gastric bypass in patients who had not yet received their oral hypoglycemic agents. And this doesn't happen with other GI operations. It doesn't happen after cancer resections. It doesn't happen after lap choles. It was unique to this particular GI manipulation. And specifically, he and colleagues at the time initiated an academic pursuit to elucidate what physiological mechanisms these operations affect, and specifically then how that impacts on the metabolic processes of obesity and diabetes. So nowadays, the three most commonly performed operations worldwide are these three listed here. The gastric band I'm going to leave aside because we're actually starting to abandon that operation as well. It doesn't have the same physiological benefits as the two that I've highlighted, which are the sleeve gastrectomy and the gastric bypass, which change intestinal anatomy to achieve these metabolic benefits that such as type 2 diabetes remission. So the sleeve gastrectomy is an operation that involves removing 3/4 of the stomach. So it removes the bulk of the greater curvature of the stomach, leaving a lesser curved based small gastric pouch. And intestinal continuity is not affected at all by that operation. The gastric bypass on the far right involves making the stomach smaller into a small little pouch that's roughly about 50 mils, 30 to 50 mils in size. And it involves rearranging the small intestine in this pattern that allows quicker transit of oral intake down the gut to the distal gut. And both of those operations make up at least 90% of bariatric procedures worldwide at the moment. So these procedures are all performed laparoscopically and in accordance with the principles of an enhanced recovery program. So this means that we admit patients for these operations on the day of surgery. The operations take 1 to 2 hours. The length of stay is usually just 2 nights after surgery. And these are safe operations. So the mortality, the death rate from these within 30 days is far less than 0.1%. In fact, it's the very same as the mortality rate for a laparoscopic cholecystectomy, which is considered a routine and safe operation. The major complication rates, such as leak or bleeding, is also extremely low at about 1%. I think often individual cases highlight the clinical perspectives and outcomes really well, more than reams of data. So I'm going to highlight 2 cases that show you what has prompted a lot of the research we do to investigate the mechanisms underlying these diseases. So these are 2 of my first cases when I started in Vincent's 2.5 years ago. NB was a 47-year-old male. He was referred to our weight management clinic, which is based at St Columkille's Hospital, in November 2011. And this case actually highlights some of the, I suppose, the deficiencies in our service, which is a lengthy waiting list to get these surgeries and to get obesity treatment. At the time this gentleman was referred, his weight was 171 kilos, which would be quite typical. His BMI was 50, which would be on average for the patients presenting to our clinic there. Even though he was only 47, he had all the complications you'd expect for at that weight. He was on 3 antihypertensives, a statin, he had reflux disease, gout, but wasn't a smoker, had no psychiatric history and didn't drink alcohol. He went through a 9-month non-operative weight management program, as all patients do, was deemed a good candidate for bariatric surgery and listed in October 2012 for a gastric bypass. But as a lot of people did at the time, they languished on the waiting list for over 5 years. At which point, when I'd started, I reviewed him and he was now 190 kilos, BMI 65. And this is quite typical of people on the waiting list who at least 50% get sicker and heavier as time goes on. He also in this time had developed new symptoms of sleep apnea, which was confirmed and treated, and he had new joint disease as well. So when I reviewed him, I changed the plan from a bypass to a sleeve gastrectomy, because for somebody that heavy, the sleeve gastrectomy is a safer operation when BMI is probably over 55, but certainly over 60. A bypass is quite technically challenging to do. So we performed a sleeve gastrectomy, and again he recovered, as most patients do, uneventfully, discharged home on day 2 post-op, and I'll just show you his post-operative outcomes. So on the day of surgery, he was 198 kilos. He'd even gotten heavier since I first met him. And 18 months later, he's down to 125 kilos. He's lost 37% of his total body weight, which he does fall into a category of being a super responder. But his weight loss has been quite effortless, in that the major benefits of surgery he feels are that he is not hungry, he feels full, his taste and food preferences have changed for the better, and he's enjoying a far healthier lifestyle without a feeling like he's on a diet, in his own words. What we celebrate is the following. So he is now normotensive on just one of he previously was on 3 antihypertensives. He has a normal lipid profile off his statin. He's off his CPAP for sleep apnea. He has no joint pain and can cycle to work. And his quality of life has improved. And he gives me his permission to tell this story of what matters most to him is in terms of quality of life. He used to be able to fit in a shower that he had at home. It was a sliding door to get into the shower, and as for his whole adult life he had to shower outside with a hose, so he never had a warm shower as an adult. And about 6 months after surgery he was able to fit into the shower at home and had his first warm shower. So he really said he didn't care whatever else happened after that. He was met up just by being able to do that. So there are things we don't celebrate, we don't even think about, and to be fair, no amount of research can really quantify the benefits of that, or they're the intangible benefits of surgery that, again, we can't even celebrate them enough. Again, surgery is never without adverse events. He's fortunate he hasn't had any. We do check really carefully for them. He's had no nutritional deficiencies, and he's extremely compliant with the recommended vitamin supplement regime after surgery, which is not onerous. It's a daily multivitamin, calcitude D3 forte to maintain bone health, and a quarterly B12 injection as well. So the second case that I'll highlight is, again, a young man, 44 years old. He isn't as heavy as the previous guy. He's 135 kilos. And when he was referred to me just over 2 years ago, his most debilitating health problem was severe and brittle asthma that had really just developed as an adult. He didn't have it as a child. Despite being in St Vincent's University Hospital, which would be considered a quaternary referral centre for respiratory disease, it was still really hard to manage it. In fact, he'd spent 2/3 of 3 years in hospital being treated for both infective exacerbations of asthma and even respiratory failure for a lot of that time. So he was well known to everyone in the respiratory service in Vincent's, and even intensive care, as he'd been intubated and ventilated quite a lot. As a consequence of his asthma, so the treatment including steroids, he had developed quite brittle type 2 diabetes. And again, in Vincent's, which will be, tertiary quaternary referral centre for endocrine disease, couldn't manage his sugars. His A1C was 12% despite over 200 units of insulin and 3 oral hypoglycemics and Victoza, so which is liraglutide or a GLP-1 analogue. So again, impossible to control his blood sugars. He also had sleep apnea and hypertension, and he had terrible reflux. So when he drank, we were able to see on X-ray that he just spilled oral content into his airway, and I think that was triggering his asthma. So the best intervention for this man, based on all of his, not just his obesity, but also his reflux, is a gastric bypass. A gastric bypass is the best anti-reflux operation that we can do. There is another one, a Nissen fundoplication, but it's not effective if your BMI is over 30. It has a failure rate. So a gastric bypass really is a one-hit wonder for this gentleman, even though he's really high risk for an elective operation, high risk for any operation. But because it's the right thing to do, we prepared him really, really well for this surgery. And part of the benefits of bariatric surgery, it's not down to just the operation, it's about the preparation beforehand from a whole MDT and the follow-up afterwards that gets the best out of these operations. He, being as sick as he was going into surgery, needed intensive workup by the anaesthetic department, endocrinology, respiratory, physios, and psychology. He had to be prepared for about a higher mortality than other patients coming in, which he was, because he felt that he faced death every day from potential respiratory failure. So 18 months ago, he underwent a laparoscopic gastric bypass. It is not typical to have to admit these patients to ICU post-op, but we did plan for that for this gentleman, fearing that he may not extubate well, but he did. He extubated uneventfully after the operation and just spent a night in ICU as a precaution. He got to the ward on day 1 post-op, and I kept him 2 days longer than usual just to watch for complications, particularly infectious and respiratory complications, and thankfully he didn't develop any. And now 18 months later, he's not been back in hospital since. He's come off his steroids. In fact, we had to do a synactin test to make sure that his own adrenal glands worked because he'd been on steroids for so long. So he was able to produce endogenous glucocorticoids. He's no reflux. His type 2 diabetes is, I can't say it's in remission because his A1C is just over 42. So his A1C is now down to 46. Remember, it was 112. But he's off all of his medications except for metformin. We keep people on a very low dose of metformin to try and maximize insulin sensitivity. He's only lost 39 kilos, I suppose, in our population isn't a huge amount of weight, but he's achieved all of this benefit with quite modest weight loss overall. And again, his quality of life has improved remarkably. In fact, the one complication he has had is that he's had a lot of adjustment problems to adjust back into normal adult life, to being a dad, and he owned a shop with his wife. So he's had to have some cognitive behavioural therapy to try and readjust to normal life because he'd spent so much of his time in hospital. He was quite institutionalised, but that's been successful. So these aren't just the best cases that we have, these are quite typical results. In terms of weight loss, they would be the typical results you'd achieve after a sleeve and bypass. So roughly, I've highlighted excess weight loss here. Surgeons like to use bigger numbers wherever we can, so a proportion of excess weight loss is always higher than total body weight loss. But this equates to, the typical result for a gastric bypass would be about 30% of your pre-op body weight, which equates to about 65% of extra weight. And for a sleeve, roughly about a quarter of your current body weight is what someone would typically lose if they're obese. And the main benefit of it is that that weight loss is sustainable in the long term. And all of these benefits are possible with surgery. So every organ system that's affected by the disease of obesity can be improved through this significant weight loss. But the particular benefits I want to highlight to you are those on type 2 diabetes, cardiovascular disease, and also I'll mention cancer. So firstly, with regards to the effect of surgery on type 2 diabetes, there are now 16 randomized control trials that have investigated or compared bariatric surgery versus best medical therapy for patients with obesity and type 2 diabetes. So of almost 1,000 patients, over half of whom have had bariatric surgery, the data is quite striking. It shows that diabetes remission rates are significantly higher in surgical patients compared to those treated with best medical therapy, an odds ratio as high as 76. So it's quite it's so convincing, and yet we still have trouble getting a lot of endocrinologists to refer patients for this, despite the evidence being as clear as it is and being level 1 at this stage. From this meta-analysis of these randomized control trials, there are other notable benefits to metabolic surgery. that compared to best medical therapy. They include better improvements in systolic blood pressure that can be achieved with medicine alone, better improvements in lipid profiles, particularly with regards to lowering triglycerides and increasing HDL. Overall, you can achieve a reduction in medications that you can't seem to do with best medical therapy. In fact, they escalate. And you achieve a quality of life improvement that's not possible with increasing medical therapy. In these 16 randomized trials, there was no deaths in the surgical group, and there were no cardiovascular events after surgery in any of the 16 studies. There is a morbidity, and it was acceptable across the 16 studies. In fact, the commonest complication from these was an iron deficiency anemia that was noted in 15% of patients, and that's treatable. So these findings raise an intriguing question about the effects of metabolic surgery on type 2 diabetes. It's been well explored in people with severe obesity, so BMI well over of 35 and over, but it leads us to ask the question as whether these operations could be effective in people who are less obese, so even just overweight. So we've looked at all the data. These operations have been performed on patients, particularly in Asia, who have where there's a high prevalence of type 2 diabetes at lesser weights. So even it's indicated there where BMI is over 27. And that data is really interesting because of 11 studies, only 5 of these are randomized, mind you. But they have included over almost 300 patients who've had metabolic surgery compared to best medical therapy. And again, the results are in favour of surgery, showing that surgery can achieve diabetes remission far more often than medical therapy can, with an odds ratio again as high as 31. And what's interesting about this is that these effects actually occur without significant weight loss in this population of overweight or mildly obese individuals. So across these 11 studies, the overall decrease in BMI in the surgery group was just 4 BMI units, so not particularly a large amount. And this indicates to us that there are mechanisms at play in improving glycemic control other than just weight loss. So again, the next question that arises is whether these impressive results on glycemic control can also extend to the complications of type 2 diabetes. So can metabolic surgery impact upon the end organ complications of diabetes that are quite devastating for patients? These are the microvascular and macrovascular complications, such as diabetic kidney disease and cardiovascular disease. So firstly, let's look at what happens to kidney disease. So we know diabetic nephropathy is common. It affects over 40% of diabetics, and it's a cause of significant morbidity and mortality for patients with type 2 diabetes. It's also very difficult to reverse. In fact, the intention of most medical therapies for diabetic kidney disease is to stabilize it and prevent progression, but very rarely can medical therapy, if ever, reverse it. So years ago, when I was doing fellowship in Cleveland Clinic, I looked at the renal outcomes of 52 patients with obesity and diabetes who had established nephropathy at the time of their gastric bypass, and then had more than 5 years of follow-up. And to my surprise, we found that patients with microalbuminuria documented pre-gastric bypass, this actually regressed completely in 58% of patients and remained stable in the other 42%. So none progressed on to either macroalbuminuria or to worsening renal disease. And in those who had macroalbuminuria at the time of surgery, 50% of these regressed and 50% remained stable. And that's not the natural history of diabetic kidney disease, which would be for it to progress in at least 40%. So here at the Diabetic Complications Research Centre, led by Professor Godson, Prof. LaRue and Neil Docherty, these findings have been confirmed at a histological level, we're elucidating the mechanisms by which diabetic kidney disease regresses after metabolic surgery based on these findings, which have been validated in other clinical studies since, including some of those randomized studies that I mentioned a couple of minutes ago. So I next want to show you how metabolic surgery affects cardiovascular disease, which is probably the second biggest complication of obesity. So long-term data from the Swedish obesity subjects study. So this SOS trial is probably the best bariatric surgery observational study done to date, that looked at 2,000 patients who had bariatric surgery and 2,000 obese patients who had just diet and lifestyle interventions. And they've followed them now for over 20 years. So it's really informative in terms of clinical outcomes after bariatric surgery. And what they've shown with regards to cardiovascular disease is that with an average of at least 15 years of follow-up, the SOS study demonstrates a decrease of fatal cardiovascular events by as much as 46% in the bariatric surgery group. That's what's shown on the graph on the left. There's also a 17% reduction in total cardiovascular events, that's fatal and non-fatal events, in the surgical group compared to patients who were obese and had non-surgical treatment or no treatment. And interestingly, this mortality benefit, was not associated with the baseline BMI or with the amount of post-operative weight loss, again suggesting that weight-independent mechanisms may be responsible for the cardiovascular benefit as well as the benefit in terms of type 2 diabetes. My previous colleagues at the Cleveland Clinic have very recently gone on to publish what's now considered one of the leading studies documenting the benefits of metabolic surgery on cardiovascular disease. So from their own data series, they've now reported on the cardiovascular outcomes of almost 2,300 patients compared to over 11,000 control patients who had obesity and type 2 diabetes who did not have surgery. The follow-up is short at just under 4 years overall, and the primary outcome of interest when they looked at their data was the incidence of major adverse cardiovascular events. And for that term, they used a composite of 6 different cardiovascular outcomes. And the main finding from this study was that there's a 40% decrease in major cardiovascular outcomes in surgical patients. And the breakdown in terms of the 6 individual cardiovascular outcomes is listed here. So there's a 42% decrease in mortality overall, a 62% decrease in heart failure, 31% decrease in the incidence of coronary artery disease or events, 33% decrease in stroke, and a 60% decrease in progression of kidney failure. And again, these are outcomes that can't be achieved with medical therapy at the moment. So the authors concluded that by operating on 13 patients with obesity and type 2 diabetes, 1 life can be saved. So there's a good return on your investment in terms of surgery. So while type 2 diabetes and cardiovascular disease are significant causes of morbidity and mortality in obese individuals, the complication of obesity that's rapidly becoming the greatest threat to life is cancer, as Tim mentioned at the beginning. We know that almost every visceral tumour has been linked to obesity, and it's now a much greater risk factor for cancer than smoking. In fact, the only cancer we can't attribute to obesity is lung cancer at the minute. And in fact, 40% of cancers are attributed to obesity at present, the most prevalent being postmenopausal breast cancer and endometrial cancer, as they're largely hormone driven. There is evidence, however, that bariatric surgery can modify this risk. So there have been several large longitudinal studies that have shown that surgical weight loss can lower the risk of developing many cancers. And this is the most recent systematic review that summarises all of this data. It summarises over 22,000 surgical patients compared to 66,000 controls, and it demonstrates a 33%, so a third reduction in the risk of any cancer, and a 41% reduction in the risk of obesity-related cancers. And the highest risk reduction is achievable for postmenopausal breast cancer, colon cancer, endometrial and pancreatic cancers. And they're the cancers that seem to respond best to that degree of weight loss. So in terms of having shown you a lot of the clinical observations from thousands and thousands of these cases around the world, I'll now just briefly delve into the mechanistic insights that we have from exploring these a little bit further, and I'll show you some of the work I've previously done that's of interest, that's still of interest to me. So in terms of the mechanisms of how these operations work, we obviously know that weight loss is important. So evidence to corroborate this is that the amount of weight lost after surgery does often correlate to the proportions or the likelihood of diabetes remission. So the operations that lead to the greatest weight loss also lead to the greatest rates of diabetes remission. Similarly, if patients regain weight after surgery for whatever reason, they are more likely to get recurrence of diabetes. So weight loss is important, but we have learned, and I've alluded to it, that there are weight-independent mechanisms at play. And evidence to support this stems from the observations that the effects on sugar control do occur immediately after surgery, so within hours, if not days, and that's before any significant weight loss has occurred. And also, as I've shown you, leaner patients, even those just overweight, can also experience similar remission rates as severely obese type patients with type 2 diabetes, despite much more modest weight loss. Also, we notice that remission of diabetes is higher after certain procedures where there's a greater change in intestinal anatomy, such as with a gastric bypass, compared to a gastric band, where you won't see the same metabolic improvements, where you've just placed a silicone band around the stomach and you really haven't altered intestinal anatomy at all as a result of that. So all of this highlights the weight-independent mechanisms at play. And it's clear from the work that has been performed that it's a constellation of factors rather than just a single overarching mechanism that likely mediates postoperative metabolic improvements, particularly glycemic improvements. So the changes in intestinal flow after surgery lead to a dramatic change in postprandial secretion of certain gut hormones, such as the incretin, GLP-1 in particular, but also in GIP, peptide YY. And we also know that ghrelin levels, which is our hunger hormone, decrease quickly after surgery, and leptin levels, which affect our satiety, increase. Surgery causes a beneficial change in the inflammatory milieu, again very early after surgery, and I'll show you shortly some of that data. It also improves insulin sensitivity. It enhances beta cell function, probably or possibly through changes in intestinal nutrient sensing mechanisms. It also leads to alterations in plasma bile acids and in the gut microbiome. So all of these are implicated in improving insulin sensitivity and glycemic control postoperatively. So again, I'd just like to highlight some of the findings from mechanisms I've explored over the last few years through training and more recently in practice in St. Vincent's University Hospital. I've been particularly interested in assessing the inflammatory milieu in obese patients because it's implicated in many of the complications of obesity, not just diabetes and cardiovascular disease, but also in cancer etiology. So in this small prospective study of just 15 Roux-en-Y gastric bypass patients, I looked at the early effects of a gastric bypass on a whole constellation of inflammatory markers. And apologies if it's hard to read them here, but what we noticed was there were favourable decreases even as early as 3 months post-operatively in pro-inflammatory markers such as CRP, leptin, fibrinogen and PAI1, and there's a corresponding increase in the anti-inflammatory mediator adiponectin. So as I said, these are evident as early as 3 months post-op and are more profound at 6 months post-op. And since then, we've gone on to show that these last into the these improvements in the inflammatory milieu last into the long term. Insulin sensitivity, as determined here by the HOMA-IR method, improved again as early as 3 months post-op, indicated by the red line, and further again at 6 months, which is the line on the top. I've also looked at brachial artery diameter and reactivity testing, which is a really good surrogate marker of endothelial function. And in this study of 15 patients where we looked at brachial artery diameter and reactivity, we found that there was early reversal of endothelial dysfunction, which was indicated by a significant improvement in brachial artery reactivity, again as early as 3 and 6 months post-operatively, and overall found an increase in brachial artery diameter at 6 months post-op. So next mechanism that interested me was looking at regulators of lipid metabolism, particularly ceramides. So ceramides are lipid molecules which complex to LDL in the liver, and they are major regulators of lipid metabolism. So they can accumulate in many tissues where they cause lipotoxicity, and they have been identified as strong novel risk factors for cardiovascular disease, and particularly cardiovascular mortality. Importantly, there is no drug treatment that can lower ceramide levels, so statins don't lower them. We measured a whole array of plasma ceramides in a series of Roux-en-Y gastric bypass patients, both pre and post-op, and found significant early decreases in most ceramide subspecies, but also in total circulating ceramide levels. So for the first time, it looks that these interventions can lower ceramides, which drug therapy isn't able to do at the moment. Another mechanism that we've looked at is looking at apolipoprotein levels. So apolipoproteins are important cholesterol transporters, and they're involved in the transcriptional regulation of lipogenesis. They enhance the susceptibility for lipids to aggregation in arterial walls, so they are strongly linked to cardiovascular disease. And the two most clinically relevant apolipoproteins are ApoA1 and ApoB100. The latter in particular is atherogenic, as it transports both LDL and VLDL. Cholesterol. And again, while statin therapy can lower your LDL, it does nothing to lower apolipoprotein levels. Not surprisingly, when we looked at levels of these apolipoproteins in obese patients pre-op, they were significantly elevated, but by 3 months, and again at 6 months, they were significantly decreased, particularly ApoB100, which led to a corresponding improvement in the ApoA1 to B100 ratio. And this reflects a significant improvement in cardiovascular risk mediated by these apolipoproteins. So having very superficially explored just some of the mechanisms underlying how metabolic surgery works, next step is to explore this at a molecular level to deepen our understanding of the disease of obesity, but also its complications, in the hope, I guess, that we can begin to develop novel, valid therapeutic strategies. So I have a particular interest in microRNA expression stemming from my PhD work at NUI Galway back in 2010 to 2012. At that time, my primary goal was to explore microRNA expression in different diseases, but particularly breast cancer. But I also wanted to apply that and explore if microRNAs were dysregulated in obesity and see if there was a link between those dysregulated across breast cancer and obesity. So just for your information, microRNAs are tiny non-coding RNA molecules which play an important role in governing gene expression. In fact, they control probably well over a third of our protein coding genes. They generally target the 3' untranslated region of messenger RNA, and by binding here with either perfect or near perfect complementarity, they can result in suppression of protein translation or degradation of messenger RNA. So they play an important role in governing many normal cellular processes, but dysregulated microRNA expression underpins many pathological processes. MicroRNAs have key roles in the development and progression of many cancers, but also in metabolic diseases. Another interesting thing about microRNAs is that they are detectable in the circulation, and this makes them ideal, non-invasive disease biomarkers. In fact, we were one of the first to find them in circulation in whole blood during that work from my PhD in Galway. So having established then an obesity biobank in Galway University Hospital at that time, I explored the role of these microRNAs in obesity and various metabolic diseases. So we found that microRNAs can target fat, pancreas, colon, liver and brain tissues to affect a variety of metabolic processes, including adipocyte differentiation, proliferation and growth, insulin secretion, cholesterol synthesis, and even appetite regulation. And in the first in vivo study of microRNA expression in fat tissue, I performed microRNA microarray on different adipose tissue samples. So that means both omental fat and subcutaneous fat from a cohort of patients who were having bariatric surgery. And then I got similar fat tissues from 10 control patients who had normal BMI and were having was able to take fat tissue at the time of elective laparoscopic surgeries, such as laparoscopic cholecystectomies. At that time, the arrays were less sophisticated than they are now, but nonetheless, we probed for 96 microRNA sequences, looking at the differences between obese and lean individuals, and also between the different fat depots. And interestingly, we identified a number of microRNAs which were differentially expressed in omental fat from obese people compared to lean people, as well as in omental fat compared to subcutaneous fat. So for example, looking at the differences in microRNA expression between these two fat types, they're completely different. Subcutaneous fat seems really quiet, if you like, at a molecular level. There's far greater dysregulation certainly at a microRNA level in omental fat. And I think this reflects intrinsic differences in metabolic activity between these two fat depots. So I then went on to quantify microRNAs, a panel of them, in the different types of fat between obese and lean people, and found a number that were significantly dysregulated, particularly miR17-5P and 132, which were both decreased almost 20-fold in obese or mental fat. I was also able to quantify and validate this in the circulation, which I thought was interesting. So the same panel of microRNAs were detectable in the circulation of obese and lean patients, and the same relationships in terms of dysregulation were mirrored in blood. And again, miR17-5P in particular and 132 were significantly decreased in the circulation of obese patients. So again, highlighting that these are good biomarkers for metabolic disease. miR17-5P really came out strongly as being implicated in obesity and metabolic disease. Its expression correlated well and inversely with BMI in both fat tissue and in blood. So it certainly appears that loss of this microRNA is implicated in obesity, specifically in visceral obesity. And while this was a really small body of work, I think it does indicate a potential role for microRNAs in the pathogenesis of obesity, and highlights the potential of using microRNAs as either biomarkers but also as therapeutic targets for obesity and its related diseases. So since our pilot study, data has since accumulated, both validating these findings but also identifying many other microRNA targets in rat models of obesity and also in obese humans. And interestingly, with regards to miR17-5P, it has been identified to be decreased in plasma of patients with coronary artery disease and obesity. And of particular interest to me is that when studies have been done transfecting miR17-5P mimic in vitro, so in other words giving back microRNA or microRNA replacement, it can alter adipogenesis in a mesenchymal stem cell population. And it does this via regression of BMP2. So I thought that was really interesting. And the exploration of microRNA in metabolic diseases, although still in its infancy, clearly holds enormous potential. And hopefully it's something we'll work on here in the coming years. So at present, obesity and metabolic surgery research in Ireland is thriving. And here at UCD, we are leaders in this field and have potential to continue to lead in this field. There's a really strong legacy of obesity and metabolic research at UCD over the past decade. Again, here at the DCRC, led by Prof. Godson, Prof. LaRue and Prof. Doherty, and at the Obesity Immunology Group, led by Professor Donal O'Shea. They've been at the forefront of translational research in obesity and its complications over that time, and I'm delighted to be working with both groups now. Just one example of the funded studies here is the US-Ireland Research and Development Programme. It was a unique initiative involving funding agencies across the US, the Republic of Ireland and Northern Ireland, and in 2016 it awarded a $2.5 million a grant to fund a tripartite study here at UCD, at the University of Ulster and at Florida State University, with Prof. LaRue as the PI, to investigate a broad range of effects of gastric bypass surgery, including changes in appetite, food preference and metabolism. And that's near completion at the moment with interesting findings. We've also recently established an obesity and cancer research group along with Professor Donal Brennan to explore in particular the effect of intentional weight loss on female cancers. And I'll just highlight one of those studies that we have initiated across the Academic Health Science Centre. So it's a multi-centre study across the Mater, St Vincent's and UCD. It's a prospective clinical cohort study where we're looking at the feasibility of intentional significant weight loss to preserve fertility in patients with type 1 endometrial cancer. So type 1 endometrial cancer is hormone driven and it's very significantly associated with obesity. So patients with type 1 endometrial cancers who have the disease of obesity as well are being referred to us. They're undergoing insertion of a Mirena coil, and the intention is to try and achieve significant intentional weight loss and see the impact of that weight loss on tumour biology. So all patients are going to go on and have a hysterectomy anyway, despite having had bariatric surgery, even if they have shown decrease in size of their tumour. But our interest is looking at the histological response of the tumour, physiological changes in the patient, and safety of this approach. We've done 9 such cases to date, and I report that some of these tumours have gone into regression. Some are no longer evident hysteroscopically or on MRIs. Some are asking if they can avoid hysterectomy so that they can preserve their womb. But at the moment, we're far from that. But it's just an interesting area, and here at UCD, I know Dun & Brennan's research group are looking at exploring the mechanisms by which these tumour changes occur just as a response to slight hormone manipulation and significant weight loss. So that's really interesting. And I'll finish by showing you where we are with the clinical service in Ireland at the moment. We have a huge demand for bariatric surgery, and we're far from meeting that demand. So even it's very hard, there's no good data that estimates how many of these surgeries we need to be doing, other than the TILDA data set, which looks at adults in Ireland over the age of 50. It's the longitudinal data set for ageing based. It's Roseanne Kenny's, led by Roseanne Kenny out of Trinity and St James's. But it's probably the only data we have that gives us the numbers of patients eligible for surgery. So even if we applied nice criteria to those over the age of 50, there's almost 100,000 people at the moment eligible for surgery. And even if we were to really strictly ration it to only those patients who met the BMI criteria, had type 2 diabetes, and had complications of diabetes, there are over 11,000 patients now eligible. And I think this far underestimates the demand, given that this is looking at only adults over the age of 50. We only have a service here in Dublin and a more limited one in Galway, where until 2017, across both centres, there were less than 100 cases per year being done, which was less than 0.1% of the demand for surgery. Since then, since we've established the bariatric surgery service further in St Vincent's University Hospital, we operated on a hub and spoke model. So with all the outpatient work done in Model 2 or more peripheral hospitals, such as St Columkille's, and surgeries being done at St Vincent's and St Michael's Hospital to achieve greater capacity. So in terms of our volume over the last 2.5 years, we've made massive improvements in terms of the amount of cases that we can do and put through safely. So we've done 264 cases in the last 2.5 years. The demographics are as you'd expect for a bariatric cohort. Our mean BMI is heavier than that internationally at 52, which probably reflects the severity of our waiting list, I think, and how hard it is to access the service. But our outcomes are good. We're doing about 57% sleeves, 43% bypasses at the minute. Again, that reflects the risk profile of our patients. They are quite high risk because they've waited for so long and have so many complications of obesity accrued at that point. In terms of our outcomes, we have had no mortalities. Our mean length of stay is only 2.3 days, so these are not a major drain on resources in our hospitals. They're in and out quite quickly with very favourable results compared to international standards. So our morbidity is acceptable, it's less than 10%. That includes minor and major morbidity. Readmission rate is very low, 3%, and reoperation rate 2.7%. That's often for gallstones to remove gallbladders because people can develop gallstones when they lose weight quickly. Our weight loss is as you'd expect, given the data I showed you earlier, as is our improvement in obesity complications. So we're achieving the same remission and improvement rates as has been identified in the randomised studies that I highlighted earlier. So I'll summarise there by I hope I've shown you, oops, sorry about that, but it's supposed to summarise that bariatric surgery leads not just to weight loss, but to significant improvement in all of the obesity complications that exist. It lengthens life, it decreases cardiovascular mortality, it decreases cancer risk, but above all, it's a really exciting area to research to give us insights into the pathophysiology of both obesity and type 2 diabetes and cardiovascular disease and cancer that will hopefully lead to novel therapies for these diseases going forward. So I thank you for your attention and welcome any questions.
Okay, I'll open up for discussion. We have a couple of minutes. Any particular pressing questions? You might actually introduce yourself so I know who I'm speaking to.
I'm Dennis Shields here from the Tommy Institute. I was just wondering, what happens when you do the bypass? What happens to all the stomach acid and enzyme secretions? Do they just get way down regulated, or do you get much less of it happening, or is the stomach isn't really being used anymore? Is it?
Yeah, it's not in that there's no transit of food into it, but it's still being stimulated.
When you're hungry, it's producing all this acid and all these
Yeah, I think the levels seem to be less. So all that acid gets diverted and mixes with food further downstream. But in terms of the quantity, like we know from, I suppose, animal studies and that if you, the mucosa changes, from it being rested. But in terms of the amount of acid, bile, and other gut hormones, they are changed, but they still are secreted. So even, for example, the greater curvature, which we know if we measure ghrelin levels, so even though the greater curvature, the stomach is left in, and it can be stimulated by other senses, such as sight, smell of food, the levels are less. So it seems not to be stimulated as much by not getting direct contact with food.
You might remind us of that, because there's not a dead end. Remind me of the anatomy of that. So you've got a bypass, but that piece of stomach you're not using, is that, are you connected to that distally, or is it closed off?
It's connected distally, so it's still healthy on its blood supply, and the transit of what's, I suppose, liquid acid in juices is diverted about a third of the way down the intestine.
The jejunum
Yeah,
somewhere.
yeah. We can modify that length to achieve greater or lesser degrees of malabsorption if we wanted, but the
What were you
standard
thinking
lengths.
of? You're thinking of over just
It's intrigued what the biological consequences
Yeah, absolutely,
are.
yeah, sure.
If you're heavily reducing the acid and the enzymes, is that having effects on the hormonal changes? Like, does the fact of shutting down the stomach
Yeah.
benefit?
That's one of the, it's probably one of the major mechanisms. So there's a theory, we kind of worked for years off two theories as to how these operations work. A foregut theory and a hindgut theory. The foregut theory that by resting, particularly duodenal mucosa, it leads to a lot of these major benefits. And we've since gone on to know that that is a major mechanism play. Just resting that segment of intestine is really important, not for weight loss, but for metabolic improvements. So there's now endoscopic therapies where you can exclude that part of the GI tract. So you can put plastic sleeve liners along the duodenum that stop contact of food with the duodenal mucosa. That leads to quite significant improvements in HbA1c, for example. You can also ablate and burn the duodenal mucosa with thermal ablation, rendering it, I suppose, impermeable, where nutrients, it affects the sensing of them. And again, that leads to not weight loss, but definite metabolic improvements in terms of glycemic control. So there is that foregut theory, so excluding the mucosa of the foregut is a really important mechanism in how these work.
The question, as a neurologist, I'm biased. I think it's gut-brain, of course, is what I think is going on, because after the brain, there's more neurons in the body and the gut than anywhere else in the world. And we've been ignoring it, and it's coming through in different areas. For example, in Parkinson's disease, it's a significant amount of evidence appearing that it may start in the gut and go transverse or transmit up through the vagus nerve up into the brain. And even some studies looking actually vagotomy might be potential, protect you against getting Parkinson's. If you had your vagus nerve done in the 1970s, your risk of getting Parkinson's ipsilateral to vagotomy was less than the contralateral side. So what about the microbiota? Everybody throws that all the time. Who's looked at it? Is it different after the bypass, and what's the relevance of that? And could that be a factor?
Yeah, it's certainly a play. It's not something I've personally worked at. I did in Cleveland look at at an animal level. It was kind of, but it's most certainly there's so many factors that influence the gut microbiome in these patients, both diet and that. But the rearrangement of gut, we know that the improvements after gastric bypass in terms of improvement or change in the gut microbiome can actually benefit. It can be used as obesity treatment. It's certainly effective at an animal level. I'd love to work more on that. I don't have any background in it, but it's one of the areas at the forefront of this field of research internationally.
Okay, anybody interested in microbiota? Have a word with Helen afterwards. Just the team, you didn't obviously a lot of people involved,
Yeah.
but managing a patient like this is big business in hospital. It's not only bed size, operating theatre size, anesthesia, ICU, there's a whole network plan. So if you're getting 2 days operative time and patients go home, it's pretty remarkable. But there's a lot of foreplanning into that, I presume. But how many people on that team put that together? And do you have to buy special beds? How do you image the patient? How do you get a CT? How do you get an MRI scan? What do you do?
Yeah, they're all significant challenges. The team is huge. So there's endocrine surgeon, endocrinologist, psychologist, dietitian, physio, nurse coordinator, and then on the ground, like all the nursing staff that are involved. In terms of the logistics, it is an issue. You can't do a lot of these operations in smaller hospitals. The corridors aren't wide enough. Older hospitals, the toilets are wall mounted, not floor mounted. Really simple things like that. In terms of beds and operating tables, most operating tables now will hold 500 kilos. That's not the issue. It's their care afterwards on the ward. You need bariatric beds ordered in if patients are over 200 kilos. So in Vincent's we've invested in them. So we're well kitted out to do it. I bring the lower risk patients to St. Michael's Hospital, which shows it can be done. A lot of the patients with type 2 diabetes have BMIs in the 40s. They can be done really, you could probably reason separating the obese population into, I suppose, a metabolic surgery patients and bariatric patients. Bariatric ones being the much heavier people with mechanical problems, and deliver metabolic surgery at different sites, Model 2, Model 3 hospitals, to create greater access. Because you don't need a lot of the resources from an infrastructure point of view to be changed for patients with BMI in the 40s. We deal with them in hospitals. Like every hospital has an obesity problem for regardless of why they're presenting.
Imaging must be a challenge then, isn't it? So
again,
CT scanning done at a certain way?
Yeah, we don't use a lot of imaging. So we do an endoscopy pre-op on everybody, which again doesn't carry many logistical challenges. But we tend not to image. Ultrasound for gallstones is probably, if they pre-exist, I would take out a gallbladder at the time of surgery. But so the weight limit for a CT in Ireland is about 180, 190 kilos. Above that, we really haven't the capacity, bar sending some patients here to the veterinary scanner. Yes. So we're really limited.
They're buying an MRI in the vet school at present as well, by the way. Just that we have MRI plus CT.
MRI, it's the girth. So if MRI is greater than 60, if your girth is 60 centimetres, which is probably for some people weight, we've had somebody 140 kilos recently who couldn't fit in an MRI. So it's major challenges. So we tend in bariatrics not to rely for looking for complications on imaging. We have a low threshold to re-intervene and re-operate to look. So because imaging is so unavailable and unreliable.
Okay, fine. I might ask Evelyn maybe to pop up just with a small little wee gift for the lecture.
Yes.
And Helen, thank you for that. Very small, but it's something to use.
Thank you very much. Thanks very much.